Testing.
Testing, no.
Yeah, it works. I hate doing this. Okay. Yeah, no, I'm just terrified. I hate sort of way. Everyone ready? Yeah. I already checked it. We're good. Okay, everyone. My name is Shai. I'm one of the PGY3 residents, and welcome to the first seminars in evidence-based medicine for the year. These will happen monthly, and involves a whole group of residents with faculty and mentor, and they go over a case from or a paper from the NEJM, and ours was the ultimate DAPT trial. So starting off with the pre-quiz data that I sent out over the weekend, the first question was the current duration of DAPT therapy post-PCI with a drug-eluting stent in patients not on oral anticoagulation? And as you can see, about 69% of the people correctly got it right, saying 12 months, which is usually with aspirin and Brilinta, aspirin and Plavix, or aspirin and Effient. The next question we had was what was the comparative efficacies of the different antiplatelet agents used in DAPT regimens in reducing cardiovascular events in post-PCI patients. And this one was more of a split difference, with the two leading ones being Brilinta is more effective than Prasugrel, and clopidogrel is more effective than Prasugrel, which is greater than Brilinta, which is greater than aspirin. The correct answer was C, green, where Brilinta has been found to be more effective than Effient, which is more effective than clopidogrel, which is more effective than aspirin. A caveat being there was a trial in 2019 called the ISAR React 5 trial, which did show that Prasugrel may actually be a little bit more effective than Brilinta. Question number 3 was which antiplatelet medication has the highest bleeding risk? And this one again was pretty split, with most people saying Effient, Prasugrel, which is the correct answer. And then I believe in response to question 3, which of the following is an absolute contraindication to the agent you chose in 3. And if you chose Prasugrel, then you were correct. And intracerebral hemorrhage is an absolute contraindication at any point in time to give someone Effient. That was the big one I was going for. Any strokes? Okay. And then the last question was, what is the duration of DAPT treatment in patients on anticoagulation who receive a drug-eluting stent after being diagnosed with ACS? And this one was also pretty mixed, and it was kind of a trick question. The two leading answers was DAPT for 6 months, followed by singlet antiplatelet therapy lifelong. And the other option was DAPT for 1 month, followed by a singlet antiplatelet medication therapy lifelong with anticoagulation. And this question partly depends on their overall bleeding risk versus thrombotic risk. Most people do about a month, which would be the orange option of dual antiplatelet therapy and anticoagulation, which would make it triple therapy. But if they have a really high thrombotic risk, you can go up to 6 months doing triple therapy.
So before we get into the actual study, we're going to have a little bit of refresher. The ACS protocol, I think we all kind of know it at this point. A lot of the steps, though, get taken before we even see the patient. A lot of times if they call STEMI, they'll call the cath lab and get everything run. And then you really see the patient if you're in ICC after, right? So just kind of like a refresher for those of us who either haven't done ICC or it's been a while since we've been in ICC. So the kind of mainstay mnemonic that we all recognize is Mona Bash. So anytime a patient comes in with a STEMI, we'll give them an aspirin, P2Y12, that's the clopidogrel, Prasugrel, all of that stuff. And then depending on if the EKG is showing a right-sided infarct, we won't give nitrates, but otherwise we would. You can consider morphine if their pain is just uncontrollable. And then if there's no other indication, like contraindications, you'll give a beta blocker, statin, and an ACE, and then they'll go to cath. One of the things that I like to tell patients is like, oh, congratulations, you just bought yourself 5 medications, because then they'll go home with those 5 medications, 2 of them for at least a year, right? The DAPT. So a little bit more background on, down. Okay, no, that's the wrong down. That's down. Okay, so a little bit further, PCI stands for percutaneous coronary intervention. So when they say, oh, this person is going into the cath lab, this is what they mean. Like sometimes they'll say PCI. If you've never heard that before, it literally just means they placed a stent. If they didn't place a stent, typically the word they'll use is angiography. So they just did an angio and they didn't see anything. But if they say PCI times 3, that means they have 3 stents placed, typically. So what happens is you'll go in through either the radial or the femoral artery with a catheter and a balloon, and it'll go to the site, and then they'll inflate the balloon, deploying the stent, and then the stent will stay in there, right? So there's the classic way of doing this is in the cath lab through angiography, where they have like an X-ray that you know, you'll see the contrast and you'll see, you know, where the stenosis is when they deploy contrast. This is very toxic for nephro patients. The other way, which is the newer way, is the intravascular ultrasound. And there was actually an intravascular ultrasound ACS trial, which the ultrasound probe is within the catheter itself. So it goes to the site. Is this red button the laser? Okay, where they go into the site and you can see the stenosis. So this is the typical angiography, and you'll see like there's a little bit of a like the stenosis, the narrowing of the vessel, and that's usually your target. Here you'll kind of see the intraluminal stenosis right there. So that's kind of your target point for that. So there was actually a trial. The trial that we're talking about is kind of a shoot off from this. So they showed in this trial that the 1-year rate of complications and composite outcomes, including cardiac death, target vessel infarction, or ischemia-driven target lesion revascularization, was lower than the angio-guided PCI. So, but regardless of that, the mainstay treatment after a PCI is placed is the DAPT therapy. And that's kind of where we're heading, right? So after PCI, like everybody said in the questions, DAPT therapy continues for 12 months, which is an aspirin plus P2Y12, so Plavix, Brilinta, or Effient typically. And then after a year, they'll continue with lifelong aspirin, and then they'll stop taking the P2Y12. But you also have to consider risk of bleeding. So you can see here on the side, I kind of highlighted the ACS protocol for DAPT therapy. This is the 12 months. So it's just kind of like a visual of how long things should go for. If your patient has a high risk of bleed, then after 1 to 3 months, the 2A recommendation is to stop the P2Y12 and continue with aspirin. If they are, if they develop high risk bleeding at 6 months, you can discontinue. Oh wait, so I flipped it. At the 1 to 3, it's discontinuous aspirin after 1 to 3 months, and then you continue the P2Y12, and then at 6 months, if they're still high risk, then it's the other way. You discontinue the P2Y12 and continue the aspirin. And then at here, depending on the patient and the specific case, typically you would discontinue P2Y12 at 12 months. But depending on them, whatever is reasonable, you can either continue DAPT, but that's also a 2B recommendation as well. So a lot of it, is clinical, discussion with your patient, but these are the guidelines for continuing DAPT after a stent has been placed. So some other studies that are similar to this, the Stop DAPT2 ACS trial is kind of similar, but they studied the effects with Plavix instead. You'll see a lot of patients, especially those that are, uninsured. They can't afford Brilinta or Effient. They're much more expensive medications. So a lot of our patients leave on Plavix. So I would just recommend reading up on these trials if you're very interested. I won't go into too much depth, but these are some similar trials that were done for this. So it brings us to our clinical question. Does ticagrelor alone versus aspirin reduce incidence of clinically relevant bleeding without increasing the risk of MACE? So basically what the study is if we stopped the DAPT and just kept the P2Y12, in this case is ticagrelor, is that just as efficient as DAPT? And does it also, prevent any, MACE events? So.
Hello. So I'm going to talk about the methods and data. So the study is a randomized, placebo-controlled, double-blind clinical trial, which is the gold standard. And so there were really two clinical trials you can think of in this one trial, the IVUS ACS and the Ultimate DAPT Integrated Study Program. This was done in different countries, mainly in China, but also in Pakistan, the UK, and Italy, 58 centers in those countries. And so it was designed to assess two different things: the utility of the intravascular ultrasound guidance for percutaneous coronary intervention, which we won't be going over the data today. We'll be going over the second part, which was comparing the efficacy of ticagrelor monotherapy versus 12 months of dual antiplatelet therapy. What is this? Wrong way. Yeah, I got it. And so I'm going to go over some of the inclusion and exclusion criteria. The inclusion criteria was quite simple, actually. It just consisted of looking for patients who were older than 18 and who had unstable angina and STEMI or STEMI. The exclusion criteria, on the other hand, really focus on factors that would lead to biases or affect the validity of the study. So for example, CKD, less than 100,000 platelets, and you can have this is all of the exclusion criteria. And you can see also that they consider things that would affect like the follow-up of the patient, because they want the patient following up, taking the medication. And so the exclusion criteria, there were a lot of criteria that they used. And so the way the study was designed was the first part focused on the IVUS aspect. And so you had about 1,753 patients assigned to either of those groups. And they went through with that study. But then what happened is after 1 month, these patients were reassigned. And this reassignment was for this second clinical trial. There were some patients that weren't reassigned. You can see the criteria for why they weren't reassigned. This criteria would have kind of affected or at least introduced some confounding variables to the second part of the trial, so they weren't included. And then what they did is they reassigned them, and then you had the different groups. You had 1,700 in the ticagrelor plus placebo, and then you had the other group, which included aspirin. And so for this, key points includes the fact that it was a two-stage factorial design. The majority of the patients who participated in the first trial, they were able to move on to that second trial. And then the randomization was stratified by the original ACS type, whether they had diabetes, and the initial intervention that they used in that first clinical trial, because that's kind of a big variable in itself. And then these were the two groups that were left over.
Okay, so I'm gonna go over the more the statistical analysis part of it. So in this trial, the first primary endpoint that we're trying to look for was there any clinical relevant bleeding with the BERC type 235. I have another table that goes over those. And then the other one was there a non-inferiority endpoint with the occurrence of major adverse effects and cardiac and cerebrovascular effects, MACE. And then they also wanted to look at other secondary endpoints, which include net adverse clinical effects, crossover effects from ticagrelor and clopidogrel, and various bleeding and ischemic outcomes. So in order for them to get the amount of patients that they needed to have, so assuming a 3% bleeding in the dual group, that means the dual platelet group in the from 1 to 12 months, the trial was powered at 80% and to detect a 15% reduction of clinically relevant bleeding in the monotherapy group with a two-sided alpha of 0.05, and then the calculation for required patients was 3,400. And then for the MACE endpoint, if we assume a 6.2 event rate between the 1 to 12 months in the dual antiplatelet group with a power of 80, to show a non-inferiority of the monotherapy with a non-inferiority margin of 2.5 and a one-sided alpha of 0.25, we need around 3,000 patients. So here, in this chart, it's what the BERC bleeding types are. It's just the guidelines that they use for in research to classify bleeding. So for type 2, it's any overbleeding that has an actionable signs of a hemorrhage. And then for type 3, it's divided into A, B, and C, and it depends on the hemoglobin drop. So for example, 3A is 3 to 5, or 3B, more than 5, and that also includes cardiac tamponade, bleeding requirement, surgical intervention, and 3C includes intracranial hemorrhage, and type 5 is the one that's like fatal bleeding. So they were looking at if the therapy would have any of those. So the principal analysis were assessed in the intention to treat population, and this included all patients that were randomly assigned the dual therapy, both the anti-dual therapy and the monotherapy, regardless if they adhered to the therapy or not. And this approach was to ensure that the results reflect the assigned intervention rather than receiving it. And the sensitivity analysis was done in the per protocol population, and this only included patients that adhered to the assigned treatment for at least 7 days, or patients that discontinued the treatment prematurely, or if they had any adverse effects. And if they had a medication possession for more than 80%. Also, one thing to note is that adjustment for multiplicity was not done for the secondary points. So those results should not be used to infer definite treatment effects. So pretty much only for the primary endpoints and the secondary and the other endpoint. And then the different types of methods that they use. So for continuous data, they were presented as mean standard deviations and compared using the t-test. And then for normally distributed data, they use means and interquartile ranges were reported. And then the Whitney U test was used for comparisons. For binary data, the binary data was compared using the chi-square test and the feature exact test, depending on the expected frequencies, and the event rates were estimated using the Kaplan-Meier method, and compare using the long rank test. And the treatment effects were estimated using the Cox proximal hazard regression, and the results were presented in the hazard ratios and 95% confidence intervals. And the Greenwood method was used to calculate the absolute difference between the absolute difference, and then 95% confidence interval for the primary and secondary endpoints.
Where's the down is forward, red is down is forward. I see. All right. Hello, everyone. I'll be talking about basically the meat, the bread and potatoes of everything, the results and the discussion portion. I'll go a little bit unorthodox, and then I'm sitting up here because I like to be the star of attention. So basically, I'll give a little bit. I have some tables up here. I'll give a little bit on essentially some of my thoughts on it because I am giving the discussion. And then I actually have a little bit further down the slide so we get past the table because it won't be there, the actual little bit more in depth, but I thought just to give a little bit of extra background on it. One of the things, because I'm part of the discussion, and it hit a little bit, Daniel did on a little bit of it, is the per protocol and intention to treat. The per protocol is what they tried to do for the patients, which meant if you missed, one single dose of Brilinta or the aspirin when you're supposed to, you're cut from it. You're taken out of the trial. You miss one appointment, you're cut from the trial. They were trying to do that just to basically try to give as much power and as evidence that that you can actually see from it instead of a patient causing X, Y, or Z happening in terms of results that we'll see. So intention to treat is very close to a similar thing, except for they'll try to include those results in with them, even though they technically didn't finish throughout the whole 12 months of the trial. So they were just trying to, like I said, make it a little more strict. You sneeze when they didn't say sneeze, you're done. So the big thing on this is there was two primary endpoints that they wanted. One of them, as we already discussed, was the MACE. So any type of cardiovascular or cerebrovascular incidents that occurred while they're on this, both either the monotherapy or the dual therapy. The second big one they were looking for is any bleeding. And then we went through all the different types of the bleedings that they were looking for, and they were trying to see, how many people are having this and this while either on monotherapy or the dual therapy. And so the big ones on here on the takeaway is 35 in the Brilinta. I'm going to say Brilinta, that's the brand name, it's just easier. The Brilinta plus the placebo, and then they actually found 78 in the trial that they actually had when they're on dual antiplatelets. So that's more than double, as we can see on there, of people bleeding when they're on the DAP therapy versus the monotherapy of just the Brilinta from 1 to 12 months while being on this. And then the second one was the major adverse cardiovascular cerebrovascular events. If you can look, they're pretty much the exact same number, 61 in just the monotherapy, 63 in the dual therapy. Maybe you can make an argument that the monotherapy is, slightly with just two different numbers, but two less, but it technically did better than the dual therapy. And then the NNT is the number needed to treat in bleeding. So I found that one, essentially you would need to treat 40 patients to prevent one bleeding outcome is what that's trying to get at. And then these are the big old the tables. The big ones that I'm going to discuss, maybe poke holes in, et cetera, is this is the big one is just to break down everything that they have. I mean, the big ones is you would think someone who's going to have a ACS, all the risk factors you would think of: hypertension, diabetes, dyslipidemia, hyperlipidemia, current smoking, all of those that most of your standard patients would most likely have because those are high risk factors for this occurring. And then the big thing on here on this table is there's a lot more males than there were females. Now, again, males run a higher risk, but it's just something to point out in terms of we saw in this trial a lot more males that were going through this than females. So does sex have any component to whether or not this actually has any effect on who should be on dual versus who should be on monotherapy? Next big one, of course, they kind of discussed most of the patients were from China that they did most of the studies. Yes, there was Pakistan, UK, Italy on there, but then that's, again, demographics. Demographics is very important because sometimes it can affect, depending on what specific comorbidity, things like that people are going through. Demographics can be a big contributor or part of it. So as you can see, compared to, let's say, the US, which has a very diverse population, most of the study that was done here was the Chinese population in China. All right. Yes, sir. Mhm. Mhm. All right. So the next big one is this is just going to break down the actual primary and secondary endpoints. Again, I brought up on the first slide that talked about the numbers that you can see on there. So you can see, and I'll have actually a chart on the next one where you can really visualize it instead of the numbers. But on the top, you see the 35 versus 78 in actual bleeding. So as you look, that's 2.1% of the patients that went through the trial with just the monotherapy versus 4.6 that did the dual plate therapy. Significant number in my opinion. And then like the second one is pretty much, it's about the exact same, 3.6, 3.7. So you can bring up the point, is monotherapy versus DAPT going to be, you know, a big difference in terms of causing another cardiovascular, cerebrovascular event as well. Let's see, the other ones on there, those were the two big ones on there. They have a bunch of the secondary endpoints that you can go through as a consideration, but the trial mainly we're looking at those 2 points. And then on this next slide, you actually get at least I think visually it helps a little bit better than using just the raw numbers. But you can see on there's a big difference, and then you can see it in terms of how long they, in terms of time, it says time since randomization. So the days go on, and it looks like you see it actually increase the longer they were on the monotherapy versus the dual in terms of the bleeding risks. And then on the bottom graph, you actually see the numbers that were shown, about 63, 61, and you see it's throughout the time, it's roughly about basically the same amount in terms of MACE that is occurring in the patients on this therapy. Mm-hmm. Less than 0.05. Red button. It's not part of my section, so. Yeah, I have on the next few slides, you'll actually get to see the breakdown on the hazard ratio in more of a graph. So hopefully visually it looks a little bit better. I was just trying to get the raw numbers as well. Yeah. Yeah, no, 100%, 100%. And then, yeah, that was the graph on the last one we went over. And then it should be on the next slide. You'll actually get to visually see this is the hazard ratio, and then the p-value is actually broken down. And so the big ones that was interesting, what I saw was age. As you can see, if you look down here, it has favors placebo versus favored aspirin. So it's breaking down on basically the reduction on whatever it is versus age, sex, or whatever, is that the placebo did better versus the DAP therapy was performed better in the primary endpoints that we're looking in here. And so this one on the primary endpoint is specifically in bleeding, and on this one is specifically in the MACE, the cardiovascular cerebrovascular events. So interesting enough, on the actual bleeding, both like age, it actually had a favored the placebo, so the monotherapy. But when you come over to the MACE, you actually see patients over 65, it was favoring actually the DAPT versus patients that were under 65 was favoring the placebo. So does age, why is 65 and older magically change on the broken down? Why does it magically change that the DAPT therapy is actually better versus the monotherapy? And then you look over here and you actually see the bleeding, the monotherapy and the DAPT are actually the same for helping in terms of lack of events happening in the bleeding side. So consideration is just, one, why is that occurring? And two, maybe, we consider the bleeding risk factor, and maybe it might be better, what do we, in our patients, if this patient is sitting in front of us, are we more concerned maybe about bleeding, or are we more concerned about them having another cardiac event on them? And maybe we might want to lean towards doing the DAPT versus the monotherapy. Something just to food for thought on there. But they broke it down into different ones, as you can see. I thought that was the biggest one that I saw on there that was interesting was age on there. But the rest are on here just for anyone that wants to specifically look at it and whatnot and some of them. But those were the big ones because those were the primary endpoints that they're looking for in all of these different subcategories. Let's see. And I guess the next one, I'll just put it on here, but is for the race, since we have a lot of Chinese males that was done through the trial. As you can see, it had a very wide range that it could be under in this hazard ratio versus on the Chinese male, you can tell it was kind of pretty much, you could go either way on it. It was right down the middle. And then same thing for the bleeding on this side is it mostly preferred the monotherapy. But again, the other, it's very wide. So when it runs through one, sometimes it may not be statistically significant in terms of favoring one side versus the other. So- Because I think there's just not a not as it's not as the sample size. That's the word. That's the word. Mhm. Yeah. Yeah. I don't remember anything on that one. That one I'm not sure on. All right. And then next we're just more of like the verbiage that we kind of went through on the discussion on whether or not monotherapy versus dual antiplatelet, and which was showing the performance on which was better or not, and things to consider. This was just more thought process behind it and more in-depth detail on it. But as the big take homes that we saw in this trial was the bleeding events specifically that was less in the monotherapy versus the dual antiplatelet therapy that was done in the study. And then we kind of went over a little bit of the limitations. Like I said, I was kind of going a little unorthodox, but things that we kind of talked about, as well as different other events that could have happened. Now I know these were just some of them. Some of them on here were actual like secondary criteria versus the primary criteria, because they included different bark types and whether that bleeding was more than the other one versus 3 through 5. And then the other thing I remember from it was, what was it? It was some of the patients also had a reduction in the amounts versus 90 versus 60, which they also included into the trial as well. But like I said, on the intention to treat and everything, they were taken out of the trial if they didn't meet any of the criteria. But some of the patients that were continued on also, instead of couldn't, for side effects, couldn't continue with the 90 milligrams of Brilinta, so they had to go down to the 60. And that was a little one tidbit of limitations through that. All right. Yep.
kind of assuming that most of the
All right. And then the last big ones is just, which like we just touched on, is it can be applicable in patients with STEMIs or previous CABGs that you could also throw in as extra part of the study. Or again, they went specifically only with Brilinta, but if you used a different one of the P2Y12 inhibitors like Prasgo or clopidogrel, and if that had any difference in terms of what would be the outcomes in this, if a study was done with them, either or. And then that was big ones. And then
So validity and generalizability. About validity, the trial's robust design, including its randomization, placebo control, double-blinded, enhanced the validity of the findings. The involvement of multiple centers and large patient population further support the reliability of the results. However, the exclusion of long-term follow-up beyond 12 months leaves a gap in understanding the extended efficacy and safety of the regimens. And then generalizability, we have multiple points, population and setting. The results are highly relevant to the patients, similar to those included in the trials, those with ACAs undergoing PCI with contemporary drug-eluting stents. However, the generalizability to different populations, particularly those with varying baseline characteristics or those treated with different stent types, may be limited. Drug-specific findings, the study focused solely on the ticagrelor. Its finding cannot be generalized to other antiplatelet agents like prasugrel or clopidogrel. And lastly, the short-term follow-up, since the study does not provide insight into optimal therapy beyond 12 months, clinicians need to be cautious when applying these findings to long-term treatment plans. Any questions?
No. The what? There was one with a cabbage. Multivessel disease. Oh, what's this last one? It was, but they said they had no, other than they had like no involvement in the data or anything. No. But I don't think it was funded by AstraZeneca, if that helps.
lot of these trials and the way we call them hypothesis, basically the trial that now we've developed. No.
We're still reading from the 3 month to 6 month gap.
No, exactly. I mean, I'm still using 12 months of data unless I can agree with
Yeah.
higher. I'll agree with 3 to 6.
And you get
But after 12 months, let's look at that's another thing. This is primarily focused on what to do in the first 12 months. Adapt versus continuing after a little bit earlier. But beyond 12 months, there's not much data out there. There are trials, and they everything compared. Ask for a low, ask for a low. No, that's not fair. Because beyond 12 months, they're really kind of like up to you. Right? Most patients says that takes 12 months, minimum 12 months. But after 12 months, like
What do you do?
what do you want to do really? And if, so for instance, someone comes in, find a patient that's like 45 young, bleeding risk is low, bleeding in their only semi, etc. And again, otherwise fine. I'm not going to stop for that. 12 months on the mark. That's finish 12 months with that. You know, it's certain this guy's got 45 or 45 at the end. That age. Whether it's on full stopping is plastic or whatever. On that for 5-10 years. They're young and otherwise healthy. Some of my practice is where we can look at everywhere, all history.
I read it last night. Yeah, very true. I think it's a relatively exciting study because DAPT has been the mainstay for a long time. If you can get away with one antiplatelet agent, that'd be really cool. But as Dr. Zay was saying, would he do it in his clinic right now? Probably not in America. In China, maybe. But there's so many factors that play into it.